Welcome to Talk Dizzy to Me, the show that brings you a comprehensive look into the complex field of dizziness. Now here are your hosts, vestibular physical therapist Dr. Abby Ross and Dr. Danielle Tolman.
Welcome back to a special episode of Talk Dizzy to Me. I'm Dr. Danielle Tolman, a vestibular physical therapist, and as always, joined by my co-host, Dr. Abby Ross, who is a vestibular physical therapist and neuroclinical specialist. And we have two very special guests that I guarantee you, all of you who are listening know. We're joined today by Helena Esmond, who is a vestibular physical therapist and neuroclinical specialist with Vestibular First. And then Jeff Walter out of Pennsylvania, who everyone knows from his Con Ed courses and previous favorite episodes of Talk Dizzy to Me. And today we're doing something different. Jeff has prepared some questions to try to stump us with ahead of time that we have no idea what they are, but we're hoping will ignite some good discussion and see if it can test the knowledge of all of us here to see, what he brings to the table. So Jeff, I'm a little scared. I'm a little nervous, but why don't we jump in with some of your questions here? We're pumped.
Okay. Well, before I try to make you all feel bad about yourselves about something you may not know, which maybe you'll know all this, I want to say that I don't know that I could be on a podcast with three females that have done more for this profession in the last 10 to 15 years than you three. I mean, maybe if we added Sue Whitney, we'd have the Mount Rushmore. Yes. Vestibular therapists who have really promoted education in this field. So I want to commend all three of you, and it's an honor for me to be on this podcast with you.
And it should be stated that this podcast started because of you, sir. You reached out and said we need to get something else going, and you promised to help us get us some guests and get some people in front of us. And here we are 5 years later, and it's just been so much fun. So this is absolutely going to be a blast, this episode, I can tell you right now.
And also, before we get started, the Talk Dizzy to Me podcasts, I think, are excellent for educational purposes. Helena also has a journal club that is still free access, Helena?
Yeah, absolutely. Always and forever.
I recommend those. I listened to some of those episodes, and it can be helpful too for those looking for expanding their education. You can exercise and throw on a podcast and listen and learn. So that's another option for the learners out there that I wanted to mention. Okay, first question.
I want to say one other thing before we get started, and that is that we have all learned so much from you as well. And in fact, today, to our audience, if you haven't checked out Jeff's MedBridge courses yet, definitely do so. They're so informative. Even if you're a more advanced provider, I love going back and before he answers the question, trying to answer it myself, which I'm hoping I'll be able to do tonight as well. So let's see what you got, Jeff.
All right, thanks. Well, we'll start out with a little history. All right. As I've gotten older, I've become interested in sort of the history of our profession. And I think it's good to know your roots. So John Epley is well known for getting a lot of credit for coming up with the concept of treating BPPV with physical maneuvers. So that's been a major milestone in otology. He was also involved in another major milestone in the area of otology. Does anybody know what else John Epley was noted for being involved with?
Is this aside from the Epley OmniMax chair?
A major milestone in otology that he was involved with. Ooh, did I stump?
No, you're doing good. You're stumping us for sure.
Right off the bat.
Right. So interestingly, John Epley was I believe he was it's a little unclear if he was a resident or a fellow. I think he was a fellow in the first successful cochlear implant surgery. So interestingly, he was present for that, which has been, has restored hearing to many individuals who are deaf. So it's so interesting that he was there for he was involved in the first surgery for cochlear implants, and then also later developed a treatment to help countless patients with vertigo. So
that's amazing. I can't imagine being a part of so many huge aspects of the kind of turning of the field, to have your name and experience associated with that. That's insane. That's absolutely insane.
Well, and my understanding is that he it was very dramatic. Like when the BPV piece, not the cochlear piece, I think. It was very dramatic that when he first was proposing BPPV treatment that a maneuver could take care of and so forth, that he almost lost his medical license. They kind of
Yeah, what happened there, Helena, is he was in the operating room doing a maneuver on someone that could not tolerate it consciously, and he did it under sedation, and it was witnessed by another surgeon in the OR, and that surgeon thought that he was doing witchcraft to the patient.
Right.
And that's how that all started.
We actually interviewed his daughter about his legacy on one of our previous episodes. So if anyone's interested in more about what his his response was, even criticism in his research, you should listen to that episode. She talks about how he used to get booed out of lecture halls if he was even being allowed to present. Like, it was insane. And now you can't even say the word vertigo or dizziness without saying try an Epley maneuver.
I know. Now every patient has BPV. It's like, wait a minute. No.
Right, true. Okay, we'll move on to Gustav Alexander. So he came up with Alexander's law. So, well, I guess my first question, and I'm sure that you guys can get this, is what is Alexander's law?
So nystagmus will increase when you look into the fast phase of the nystagmus.
Good. And it decreases when you
look away from the fast
phase.
phase.
So it'll generally, the nystagmus will be to the more neurally active side, and it's enhanced when you gaze towards the fast phase. And it's blunted when you look towards the slow phase. Anybody know why? Or is that sort of mysterious?
When in doubt, I always blame the brain. I don't.
So a way you can, there's actually a couple different theories behind the mechanism for Alexander's law, but what is our tendency, normal human, when you gaze left? When we gaze left, at end range, you can have a little bit of
end range.
left beating.
Right.
You gaze right, and you can have a little bit of brief
right beating.
Right beating. So we call that end gaze normal physiologic nystagmus. So think about it. If you have a right vestibular loss, you're sitting there and you have left beat nystagmus. Well, when you gaze left, it's sort of like pushing a car downhill. The elastic properties of your eye, your eye wants to drift back to primary gaze and snap to the left. So it's sort of like pushing a car downhill. You have your disease-related nystagmus working together with your engaged normal physiologic nystagmus. But when you gaze in the opposite direction, so you have a right vestibular loss, left beating from that, but it's blunted a bit by, well, when you gaze right, you want to have right beats. So it kind of washes it out a little bit. So that's one of the chief thoughts behind the mechanism involved with Alexander's law. So it's a really helpful rule to remember that vestibular origin nystagmus is unidirectional, and it beats to the more neurally active side, which will typically be your healthy side if you're talking about a paretic lesion. So here's my next question. Does Alexander's law apply to peripheral nystagmus or brain-related nystagmus?
Definitely peripheral.
Yeah.
Peripheral.
Yeah. It can follow it in central, but not always consistently. That's at least my clinical experience.
Excellent. Right. So it reliably follows it with peripheral disorders. It can sometimes, brain-related nystagmus can follow Alexander's law, but not as reliably. And that's not what Alexander wrote about with his law, as he stressed that this was related to peripheral origin nystagmus. So probably the best answer is peripheral, sometimes central, but you can't trust that.
Because you would think about central wise if you had direction changing gaze evoked nystagmus, right? Which is what we typically see. So I could see where it would apply to that and be significant, but in other cases where it probably wouldn't. Right.
Well, we could even see sometimes patients with downbeat nystagmus where when they gaze down, it actually stops the nystagmus, and that's certainly following Alexander's law. Okay, good. And then last on Alexander's law, Gustav Alexander. So he practiced back in the early 1900s. Well, let's go back here. If you had a negative patient experience nowadays, what would be a retribution of that. Perhaps somebody leaving you a negative Google review. All right.
Yeah.
Mm-hmm.
So Gustav Alexander had a patient who was very unhappy with the
Oh
nasal
no.
that he performed. Does anybody know how Gustav Alexander's life ended?
No.
A patient killed him.
He was assassinated. So interestingly, in 1910, his patient was likely, from what I read, schizophrenic. And so in 1910, he attempted to assassinate Gustav Alexander and failed. And then he got this patient, and I'm not even going to say his name, was put in a psychiatric hospital for over a decade. And then he was released. And several years later, he tracked down Gustav Alexander and assassinated him. He shot him 5 times in the streets of, I forget where he practiced, Munich, I think it was. Wow. So he was assassinated by an angry patient. So I thought that would be something maybe you didn't know about Alexander.
Who would have thought our jobs could be so hazardous?
Yeah, right? I hope that happens to no one else. That's terrible.
All right. So, well, we'll go on to more positive things. So a really common term we use in our field is nystagmus. Where does that term come from? Like, where did that come about? Like, why are we using nystagmus as a term for these rhythmic, slow and fast phase eye movements? What's the origin of that?
Do you sit around all day and think of these questions? Is this just what goes around in your mind all the time?
A lot of lectures over the years.
This is definitely Greek or Latin. That's always the answer.
Okay, you're on the right track. So it comes from the Greek term nystagmos. So it's spelled the same except OS at the end. And I was just thinking right before this podcast, wouldn't it be cool if you named your pet Nystagmus? Your son Nystagmus?
Yeah, your son would love it.
It's almost as nerdy as naming your dog Epley.
Right, there you go. Which was what, Dr. John's, right?
And me.
Oh, really? I didn't know that. Yeah, you are geeky.
I love it.
So what is the term nystagmos, like, where did it originate from? It was actually a term used to describe drowsiness. What does drowsiness have to do with nystagmus? Any ideas? Like, what's the linkage between drowsiness and nystagmus?
Because of the slow phase of nystagmus, maybe it seemed like the eye was lazy.
No, good guess.
Like a head lolling, maybe, like your eyes kind of lolling forward and your eyes kind of coming back up, right? Like you're trying to fight sleep.
So when you start to nod off, you'll drift your head down and jerk it up. So it's this rhythmic drifting of your head down, jerking your head up. And so when they saw the eye doing the same thing, that's how it got its term, was from the jerky head movements you make when you're drowsy. So that's how nystagmus, the term nystagmus, came about. It's Greek in origin.
Nice.
All right. Staying on the topic of nystagmus, you ladies are doing well so far. Danielle kind of figured that one out. What is Brun's nystagmus? So that's a type of nystagmus we see in patients. Does anybody know what Brun's nystagmus is? No AI use here.
Oh, I used to know this. Jeff, you made me know this.
They're named after Dr. Brun, no doubt.
It might be. I don't know. I didn't look that up.
Danny, you're our only hope.
It's on the tip of my tongue, and I'm going through all of them. I'm going through the cogwheeling. I'm going through the rebounding nystagmus, and I cannot place it. I completely forget.
So Brun's nystagmus is a red flag if you see it in a patient. And what you'll see is with gaze testing. So when a patient has a left cerebellar pontine angle lesion, when they gaze left towards the tumor, so it's in the left cerebellar pontine angle, they'll get left beating that's of low frequency, large amplitude. And when they gaze to the right, due to their left vestibular loss, they'll have a higher frequency, shorter amplitude nystagmus from the paresis created by the mass. So it's a type of tumor we primarily see in cerebellar pontine angle tumors. So that's Brun's nystagmus. So if you see this coarse, gaze evoked, nystagmus with left gaze that's large and low frequency, and then you gaze right and you see a low frequency, low amplitude nystagmus. You want to be concerned about a left cerebellar pontine angle lesion. So that's Brun's nystagmus. All right, moving on. What's the definition? So I'm looking for, there should be three things we hear with this. What's the definition of vertigo? And I use the International Classification of Vestibular Disorders as a reference, but I will say that I summarized their long definition of what vertigo is. But there should be three key components to your answer. By the way, this ICVD, the International Classification of Vestibular Disorders, is an effort to make sure we're all using the same language in different countries for describing abnormal eye movement, different terms, because that's been a big problem in the literature.
A huge problem.
People use, people describe nystagmus as rotary or clockwise or counterclockwise, so we're all trying to use the same terms. So I just wanted to start with, how do we define vertigo? So there should be three attributes of this definition that I'd like to hear, I think, to get full credit.
Well, what about the false sensation of movement when there shouldn't be movement?
Illusion.
Yep.
So we'll go with, so this false or illusionary, keep going.
Component of movement.
Can we be more specific than movement?
It's supposed to be rotary, like something's spinning. It can be yourself or the environment, as I understand, but.
Good. So that was another attribute I was looking for. It can be of self, which is subjective vertigo, or the illusion that things in the environment are moving. That's objective vertigo. So we got illusion and we got of self or environment, but it's an illusion of what? That's what I think we're missing here a little bit. Helena hit on it a little bit, but I believe it was sort of incomplete. So she said an illusion of rotation, so of rotary movement. So are we done? So it's an illusion of rotational movement of self or environment. We're missing one thing.
One thing?
It can also be linear, so it does not have to be rotary. So vertigo can be an illusion of like a shift horizontally or vertically. So it's an illusion of rotary or linear movement of self or environment. I think that's the definition we're all trying to use. All right. So now we define vertigo and nystagmus. Go ahead.
So when someone says rocking or swaying, self-perceived rocking or swaying, that would fall under that definition.
If they have an illusion of linear or angular movement of self or environment, I would say if they're objectively unstable on their feet, that probably falls under postural instability or imbalance. But if you're just talking about the sensation that they have,
The internalized sense.
Yeah. Okay, good. Moving on.
This is so much fun.
Good. We're going to talk about the bow and lean test a little bit, which one thing I do differently than Danielle when you were with me, what was it, 8-10 years ago?
Shh.
Is I do, sorry, that makes me even older. Is I now pretty routinely do bow and lean testing before I do any Dix-Hallpike or supine roll testing, because I think it's helpful to take a quick look at it. But when we do, so a bow and lean test is a test to help for listeners that may not know. It's used to help localize which ear horizontal canal BPPV is localizing towards. All right, so we have a patient bow forward and we have them lean back. And if debris is loaded in their horizontal canal, in the posterior arm of the canal, when you bend forward, the debris will migrate towards the cupula, create utriculopedal deflection of the cupula, and create excitation. So then the nystagmus will be to the affected side with bowing. And then with leaning the head back, the debris will migrate away from the cupula, causing utriculofugal displacement of the cupula and canal inhibition. So the nystagmus will be to the uninvolved side with canal lithiasis of the horizontal canal. And then the rules switch for the for cupulolithiasis, and the nystagmus is sustained. But my question to you three
Why couldn't
is,
you have asked us that? Why wasn't that our question?
As you're going, as you're going through, I was like, oh, that's all I know already. Like,
Abby, this is supposed to be vestibular 401 tonight, not vestibular 201. All right.
Fair.
Okay. So to properly execute a bow and lean test, how far forward should you bow the head?
I know this
Go for it,
because
Andrew.
I know this because I heard it in your MedBridge course today. 120
Oh, that's not fair. Were you studying for the test today?
Texas license is up on the 31st, and I was just telling them I procrastinate this every year, and then I cram, especially your courses, like for 2 days straight, because I need 30 CEUs, and
All
yours
right,
are like 1 to
You have
3.
raised my expectations that I'm going to hear the right answer. So what is the correct answer? How far forward should you bow the head with a bow and lean test?
120 degrees in the bow. And
Can you
16.
explain why to the audience?
The anatomy of the horizontal canal, you want, is it perpendicular?
So the goal is to place the horizontal canal, and Elaine has her model up if anybody needs to see it. Your horizontal canal sits oriented anteriorly. It's 30 degrees higher than it is in the back. And what's the goal of the bow test is to get the horizontal canal parallel or perpendicular to gravity. What's the right answer?
Perpendicular.
perpendicular to the floor, parallel to gravity.
Correct. So parallel with gravity, perpendicular to the floor.
Yeah.
You need to go down 120. So then how far back do you need to tilt the head for the lean portion of the bow and lean test? So
60.
the extended portion. 60. Good. So that's a common misconception. You don't need to go back as far as you need to go forward. And I found that going forward to get that canal really aligned with gravity can make a difference in the strength of the nystagmus you see. So 120 down, 60 back, because the canal sits angulated, anterior arm up 30 degrees. Does that make sense to everybody?
Abby for the win.
All right, good job, Abby.
And that's my biggest concern about the supine sit version, because I feel like it's kind of easy. You're not really necessarily, when you think sit, you're like, oh, I'll just sit them up, but that may not get it going. I find that you kind of really have to get them forward, really into a bow, actually, like, you know.
So what's being referred to there is when you have a patient with horizontal canal canalithiasis, as an example, when you take the patient and lie them supine, you may see nystagmus briefly beat, and it's helpful to look for, to see the nystagmus will beat to the uninvolved side briefly with horizontal canal canalithiasis when you first lie a patient supine. So it's just another marker to look for when you're trying to determine origin, laterality with horizontal canal BPPV. Okay, good. If I come into your clinic and I have the agiotropic form of horizontal canal canalithiasis. Everybody follow that? I have the agiotropic form of horizontal canal canalithiasis. So my debris, we see this in patients, by the way, that tend to be more kyphotic because their horizontal canal, sometimes the anterior arm's lower than the posterior arm of their horizontal canal. What would happen with a bow and lean test with that patient? Any thoughts?
So just in general?
It would act like cupulolithiasis. That's what I say.
All right. So that's one thought.
Oh. So you're not necessarily saying that the otoconia are adhered to the cupula.
Nope, I didn't say cupulolithiasis.
No.
Correct. You said the
He's saying they're in
agiotropic.
I call it the short arm. I'm hearing there's different terms, right?
Well, some people use ampullary arm because it's near the
So
ampullary.
like the anterior or ampullary or short arm of the horizontal canal.
So
if they were to bow forward, it'd be excitatory and you would get nystagmus beating to the affected ear. But when they would go back, it would go away from the cupula, creating an inhibitory effect and going away from.
Right. I would say in most cases, when you bow, nothing will happen because the debris already in the anterior arm of the canal. Bow forward, it has the lowest spot of the canal is where it's already at. So you'll get a negative bow, but when you lean, you'll still get the nystagmus beating to the uninvolved side. So it'll behave like your traditional horizontal canal geotropic form of canalithysis when you lean, but not when you bow. So that's why it's always important to do both. And not just because the bow's negative doesn't mean the lean will be negative with the patient. And watch for that more. Horizontal canal involvement overall, I think, is more common when patients are kyphotic. And this agiotropic form where the debris is in the anterior arm of the canal, again, I think is more common when a patient has kind of a forward head, stooped posture.
I have a follow-up question.
Sure.
I've also, go ahead.
No, go ahead, Helena, you first.
I was just going to say, I've picked up, and this is in the literature, so it's not like me coming up with it, a posterior canal. Like I won't necessarily see anything in the bow, but in the lean, you'll get basically, left torsional upbeat or whatever posterior canal is affected sometimes.
Yeah.
So my follow-up question was, if we were to do the bow and lean with this patient, and they have free-floating debris in the front of the horizontal canal,
right?
You do the bow, you get nothing. You do your lean, you get a response. If you were to go back into that bow, now that you've kind of loaded those crystals in the posterior arm of the horizontal canal, will you get that excitatory response for like a geotropic canalithysis, traditional?
Yes, I think it's very likely that you'll get a different result because now the debris is loaded in the back arm of the canal. You have them bow forward, and now it's going to move back to the front of the canal. One other thing I do, sometimes the debris gets hung up and doesn't want to move. I will briefly, when a patient's nose is down with the bow test, if I'm getting nothing and I thought I could get something, I'll turn their head left briefly and right briefly just to try to get the debris moving on one side or the other. So that's another little like clinical tip if you're not getting anything with your bow test and you thought you might. So when you bow them forward, wait a little bit just to see if anything happens with their nose straight towards the floor. And if you're getting nothing, just turn their nose right for maybe 15 seconds and then left for 15 seconds just to get the debris marching towards the front arm of the canal. Once it gets in motion, then it'll usually show off for you. Okay, next question. Anybody else have any questions on that? All right. You have treated someone for posterior canal canalithysis. Your typical posterior canal BPPV, canalithysis type. You're not 100% sure it was effective. So you're unclear whether you reposition the debris back to the utricle. But let's say you did, but you're going to do a retest. What would you see if the debris went from the utricle back into the posterior canal and basically you recreated their disease? In other words, in retrospect, you got the debris out of the posterior canal and you're doing a repeated test you don't need to do. And you're putting the debris back in your patient's posterior canal. What type of nystagmus are you going to see when that happens? So something therapists should be aware of if they're doing retests after maneuvers.
You want to take this one, Helena?
No, I think you seem excited, Danielle. Go.
You would get the opposite response that you would anticipate. You would get a downbeat torsional to the contralateral side.
Bingo. Very good. So a lot of when I am teaching in the clinic, a lot of times, especially when I'm with somebody that doesn't seem to put a lot of thought into answers sometimes, their reflexive answer is, well, if it's the right side, it'll be upbeat right torsion. If it's the left side, it'll be upbeat left torsion.
Ewald's laws.
And then I tell them, grab that model, that hold it up there. That thing right there is golden with explaining BPPV to your patients and also teaching. And so remember, the debris migrating from the utricle back into the posterior canal. It's going to create utriculopedal deflection of the posterior canal cupula, which is inhibitory. All right, because that debris is migrating towards the cupula, not away from it like it would be with your Dix-Hallpike test when the debris is already loaded in the canal. So Danielle hit it right on the head. You're going to see downbeat nystagmus with the torsion towards the opposite side.
which don't jump to the conclusion that this is the anterior canal.
Well, you just beat me to that. So that's one why we can see downbeat torsional nystagmus, and it's not coming from the anterior canal, which that should be like your last explanation for downbeat nystagmus, in my opinion, but that's a whole nother lecture. And
Yes.
that's still, but
You know what's fun about that though, Jeff, is that conversation about anterior canal has changed a lot in the 10 years since, I was with you. We went from thinking that it was possible, with the work with Janet Helminski, to now using her own work, coming up with a better explanation as to why it's probably not anterior canal and something completely different like short arm canal BPPV. So it's so cool that even in the short amount of time, well, I guess it's not that short, but the amount of time that I've been practicing, that there's been some updates that have changed theories on atypical BPPV, which is so exciting. This is just so cool.
Well, my opinion's never really changed.
To be fair, you're absolutely right.
We see variety in the clinic, but I think if you look hard enough, there's always a better explanation. Okay. By the way, just for the audience, when you go to retest somebody, which I do, because sometimes you do a maneuver and you're like, oh, the patient traveled far and I'm not completely sure it's cleared, and my patient's not super sensitive to it. So I think they could, even if I would put the debris back in the canal, I think they'd handle it okay. Or I have a student with me and I'm just trying to show off that the maneuvers work. So those are all reasons why you might do a retest. Things to be aware of when you do a retest is what we just talked about, which is the downbeat torsion to the opposite ear. So when you see that, you just undid your modified Epley. What are some other things we can see? Well, we can see nothing, which is good, which means the debris is evacuated out of the canal and pretty likely back in the utricle. I would strongly recommend, if you're doing a retest, do a loaded Dix Hallpike when you're doing testing, because you can be a little bit more confident that you're not getting a false negative when you do a loaded Dix Hallpike. So I would really consider doing that on your retest for a patient you just did the maneuver on for posterior canal. And then also be aware of the debris going into the horizontal canal, so you can get really brisk geotropic nystagmus. So whenever I retest a patient, and I always stress this to students, tell the patient when you're putting them back for a retest after you've done maneuvers, they've already experienced what's happened a couple of times with your positioning test, warn them, when I put you back, nothing may happen. That'd be great. It could be the same, which would kind of be a bummer, because I don't want it to just be the same as what it just was. There's a very small chance that you could feel terribly worse for several seconds, and that's if the debris goes to a different area of your ear. So always, I think you have credibility with your patient if you warn them about each scenario before it happens, and then you're trying to explain it to the patient, because they can really feel worse when that happens. And one more thing, which vexed me for years, is you had a patient who looked like they had canalithiasis of the posterior canal, real classic. We put him back for a retest, and the debris is now in the short arm, and the debris lying on top of the posterior canal cupula when you get him back in a Dix Hallpike. And what will happen with that is you'll get this light and wimpy and kind of persistent torsion, usually to the involved ear if you just have them back 20 degrees over the pillow. And you can be confident that the debris in the short arm resting on top of the cupula if you elevate their head up to what's called a half Dix Hallpike. If you elevate their head up to a half Dix Hallpike and that torsion accentuates and won't stop, you reposition the debris out of the long arm of the canal, but you put it in the short arm, which is the short arms between the utricle and the cupula. And that's a little frustrating when that happens. And I think that is the most, Elena's pointing to it for those that are visual learners. She's pointing to the short arm of the posterior canal.
Yeah.
And when that happens, it's very common for patients to feel unsteady after their maneuver. I think it's a real common reason why patients will say, for several days after the maneuver, it was different. I wasn't spinning. I just felt like I was tipping around and unsteady on my feet. So just warn your patient to be cautious if that happened. And then there's some maneuvers we try to address that. A bow and yaw maneuver is one of the maneuvers that's tried. And Elena just published a maneuver that's almost identical to it.
I know.
On vestibular first. In fact, it was really essentially the same thing. And I don't know what the name, I forget the name. It wasn't an easy name to remember, the one you published.
No, it's because it's someone's name and they're like in Brazil or something. So it's like really long and it starts with a G. And if I pronounce it, it's definitely going to be pronounced wrong.
Yeah. So,
sorry, researcher.
That's okay. Helena brings up a good point. It's been kind of a troubling area in our field. I'll just be very frank here. Patients or researchers make a very minor modification to a maneuver, rename it after themselves, and it just creates all this confusion. And I don't think that's great for our profession. I don't think you should name something after yourself if you're just making a modification to it. Use the original name and add something to that helps the learner understand, well, what's different about it. Example of that is a Gans maneuver. It's not that much different than a modified Epley's maneuver. It's just helpful for patients with back pain because they don't have to be supine on their back. But there's only minor modifications with that maneuver. We didn't need to rename it, in my opinion. I'm sure Dr. Gans would probably disagree with me, but
even just from clinician to clinician, but also for patients to remember names of things. For them everybody is an advocate for themselves these days, and they're searching for things that are going to help them feel better, especially if there's a lack of resources in their area. Yeah. So to have all these things that have long, confusing names or different names or a lot of variety, it can be very difficult, I think, for patients to get their hands on the right information.
Especially with horizontal canal BPV, there might be I'm not kidding, there's probably 20 different maneuvers now.
Yeah.
Some sort with all these different names. And that's why when we did the Dix-Hallpike study, we didn't change the name of the Dix-Hallpike. We just called it the loaded Dix-Hallpike. So it's still a Dix-Hallpike. It's just a modified way to do it. And learners can remember, I hope, what loading means. So I just thought that was a better way to term a modification to a known entity. But that's a tangent.
It's okay. So I am hoping this will help a little. We're building a library online. Erin Kilkenny, as a vestibular physical therapist that has joined our team recently, and using resources that we've built with Balancing Act Rehab, Danielle and Abby, we have handouts, and I have tasked her with every maneuver. She has if there's 6 names for this sucker, you have to list it, and then we'll link related to. So there'll be a page for the Dix-Hallpike and a page for the loaded Dix-Hallpike, and we'll link them. And so we're going to try at least to help people see what's its own maneuver, what's kind of a variation, and to continue to clarify because the research is great, but their articles can get real deep, and there was one she asked me for, I'm sure y'all are familiar with Guffoni from 1998 or something, and it was in Italian. And so she's like, I want to know, does it tell you to stay in the first position for a certain time or not? And so, luckily Google Translate helps us. So, we're able to, kind of look at what was the intention, for a given researcher and how were they doing it? And then trying to look at other studies and are they doing it that same way or different, right? So it's a challenge, but, we're hoping that at least we can try to provide more clarity, because I just feel bad for all the clinicians who are trying to sort this out,
Yep.
Patients.
Yeah. And just in my opinion, probably 1 out of every 3 maneuvers that I see that come out that's new has a step involved that totally is nonsensical. Makes no sense from a spatial orientation standpoint. So you got to be careful about taking all these new maneuvers as gospel, because I think there's some steps that are unnecessary in some of them. I don't want to just single things out, but just be an independent-minded thinker and know the spatial orientation of the ear and see if every step of a particular maneuver even makes sense to you. So, okay, moving on. Just a couple more. So a tuning fork is a very helpful tool for a therapist to have. So we're going to talk a little bit about auditory screening, because I work in an ENT practice. So our practice is really focused on making sure we ain't missing anything related to the ear. So a popular test is called a Rinne test. Can anybody explain to me what a Rinne test is? And then I have a higher level question after that.
It looks at whether or not air conduction versus bone conduction for hearing, and that can help determine between sensorineural hearing loss and conductive hearing loss. So you hit that tuning fork and you can hold that up next to the patient's ear, and compare that to then taking the tuning fork and then holding that against the mastoid, and which tone sounds louder to that. We were asking them which tone sounds louder to them.
Very good. So in a human with normal hearing, what would you typically see, Daniel?
You should hear the tone louder next to the ear canal versus
the air conduction.
The air conduction, yes. Other than bone conduction.
Okay, good. And then if you had a conductive hearing loss, what creates a conductive hearing loss? I'll give you a list. Cholesteatoma, which is a mass that grows from your eardrum and can erode into your labyrinth and your skull base. Otosclerosis, otitis media, superior canal dehiscence kind of creates a pseudo-conductive loss. So those are some common reasons to have a conductive hearing loss, where bone, when you place the stem of the fork behind the patient's ear, it's louder than when you have the tuning fork in front of the ear. So I'll continue to pick on you, Danielle, since you started. How would you document that test in your note?
Oh, I would say that, so I would, for
It
Rinne,
was normal, so your patient had...
it was normal. I would say air conduction is greater than bone conduction.
Well, is that negative or positive?
Negative. Nope. I don't put positive or negative just so that there's no confusion of what's positive or negative. I just say air conduction is greater than bone conduction.
And I think that's a great idea. When you document it, you might just want to put air greater than bone or bone greater than air. What is confusing with that test is if the Rinne test is normal, air more than bone, the test is positive.
Oh.
And if bone is greater than air, it's negative. It's a special test where a positive result is normal. Confusing. So when air is greater than bone, the Rinne test is technically positive. When air is not greater than bone, it's a negative result. A positive result is normal. That's what's confusing. So again, you might just want to go with air greater than bone or bone greater than air. But if you read notes from ENT clinic notes and it's using positive or negative, always keep that in mind. All right. Another helpful tuning fork test is called test of recruitment. Does anybody know how to test for recruitment? So it's really helpful.
What first, Jeff? Can we talk about that?
Recruitment of sound.
Okay.
It's a tuning fork test.
Okay.
So it's an auditory test. Good point. I should kind of preface it out. So an interesting phenomena in a diseased ear, and the most common time I see this is with Meniere's disease, is when you take a tuning fork and you strike it really lightly. So you just strike your tuning fork very lightly and you present it to each ear. A patient with sensory neural hearing loss from right-sided Meniere's will typically say, well, it's less in my right ear, it's louder in my healthy left ear. Everybody follow me? That makes sense, right? They have a hearing loss from their disease. They don't hear as well when the tuning fork is just struck lightly. You take that same tuning fork and you strike it forcefully. So now it's really loud. A common feature in a diseased ear is when you present it to the patient, now it's louder in their diseased ear, and that's called recruitment. And the patient will look at you oddly when it happens because the patient's like, well, that's weird. Now I heard that better in my bad ear. So it's called a test of recruitment, and if that's positive, it's pretty common that it's a feature of Meniere's disease that's pretty specific for Meniere's disease, and it's simple to do at bedside. So it's a helpful test that I do in patients that have a unilateral hearing loss that they think is related to their dizziness. So
what's the pathology? Like, is that like a, do you know what I'm saying? Like, I'm trying to think, like, is it nerve? No, maybe it's like fluid, or what's going on there?
Yeah, I've heard the explanation for it 3 times and it never sticks with me, but it's just basically your brain has become craving of information from that. Trying to bring
the brain.
And when you strike it loud, then it's overcompensating for your hearing loss. So it's a central adaptive.
A sound sensitivity situation. I gotcha.
Sorry, I should be able to give you a better explanation, but so that's a simple test to do with the tuning fork. So always remember you have your Weber, you have your Rinne test, you have your test of recruitment. And then in superior canal dehiscence, it's really helpful to take that tuning fork and put it on any distal bony landmark. I usually use the patella, and that's like 95% sensitive, meaning when you put it on a patient's patella, if they have superior canal dehiscence, they will, without saying anything to them, they'll typically point to the ear they're hearing it in, which is not normal. And it's like a vibration right up through their spine, up into their head, right into their ear. So they'll feel like that fork attenuate from their patella all the way up through their skeleton into their involved ear, because their ear's an amplifier for any sort of internally generated sound, which is bone conduction. All right, good. One last question. All right. Your patient comes in and gives you the stack of papers from all the tests they've had done. All right. And one thing you come across, and this is not uncommon, is that your patient's CT scan has suggested that your patient anatomically has superior canal dehiscence. All right. So the radiology interpretation is appearance of the right superior canal appears dehiscent, meaning that there doesn't appear to be bone between the brain and the membranous semicircular canal. Can you have high confidence in a positive test? So can we be sure that that patient has superior canal dehiscence, since it's being displayed on their imaging?
I'm saying no.
Correct. So the way you want to think about this is, if the CT scan is normal, a temporal bone CT scan, by the way, if it's normal, we can rule it out. I mean, the patient doesn't have it. So you can be confident with a normal study. When a patient has a CT and there's a suggestion that they have superior canal dehiscence, the way you want to think of it is, it means they might.
Yeah.
Because the CT underappreciates bone. So there could still be bone there, even though the CT is not picking up on it. So I would say easily more than half the patients we get referred that have that anatomically on their CT have superior canal dehiscence, when you take their history, they have no attributes that you could attribute to superior canal dehiscence. And we do third window testing with them in our clinic, and it's all normal. And the only thing that misled you was the CT. So what I'm saying is, don't overweight a CT scan that suggests dehiscence. It just means your patient might have superior canal dehiscence. So we can really trust it to rule out. You can't fully trust it that just because it's on their imaging that's the source of their dizziness, or that it's even relevant. Because again, the CT underappreciates bone. Right?
So I'm assuming if the patient's still in front of you, though, they are coming to you because they are dizzy and that they had the CT scan. They're not coming to you because the CT scan showed potentially superior canal dehiscence and they're asymptomatic, correct?
Yeah, I would say that's unusual. Usually they have some sort of dizziness symptom, but sometimes you take their history. So you got this CT report and they're referred to with superior canal dehiscence, and you take their history and it's like golden for BPPV, and it has absolutely nothing to do with why they're there. And so they've done all their Google University work, and they think that they need an intracranial surgery to fix their dizziness. And it's good news for the patient. It's much easier to fix BPPV. So I'm just telling the therapists or audiologists listening to the podcast, be a little careful when you see that in a report, and physicians be careful about it too. That just means it's possible. It doesn't mean that's why your patient's dizzy. So you need that clinical history. You need third window tests that are supportive, which would be looking for a Tullio's phenomena, Hennebert's sign. That's nystagmus with sound, nystagmus with pressure, a VEMP or OVEMP test supporting it, which should be abnormal if a patient has superior canal dehiscence. Pulse synchronous nystagmus. So nystagmus that's right in sync with your patient's pulse, because every pressure wave in their brain is coming down through the dehiscence. Those are some things to look for. So you guys did pretty well.
I have, along these same lines, a case that I was listening to, one of your cases, where I think maybe the patient initially stumped you, but when you started to put all the puzzle pieces together, you ended up coming to the conclusion. And I wanted to bring it up tonight. It was a patient who was complaining of dizziness when he coughed. Do you know what case I'm talking about?
Yeah.
So
Right.
I did not, I don't want to give the answer away without you explaining or us thinking through it, but I did not get to that conclusion initially.
Yeah, actually, Helena, we did a podcast on this.
We surely did.
Yeah,
A
so
while ago.
We will link in the show notes for sure.
there you go. So this
Great case.
in a small subsection of patients with vestibular schwannoma, they can get really strongly vertiginous with increased intracranial pressure. And so coughing increases your intracranial pressure. And for the patient that Abby's referring to, that was his only sign of a schwannoma. His audiogram was normal, his caloric was normal. I looked for hyperventilation-induced nystagmus, head impulse, everything was fine until he coughed. When he coughed, he got really violent nystagmus, and he had a vestibular schwannoma that was crowding his eighth nerve. And when you exerted pressure in that area, you could induce a transient, pretty strong nystagmus. It's on YouTube, by the way. If you put in cough-induced nystagmus, I believe it's the first thing that comes up, because there ain't many videos of cough-induced nystagmus on YouTube.
Well, we'll be linking everything that we talked about in this episode, because there's a ton of resources, a ton of great things that we talked about. Like this is a gold mine, this whole episode. We'll be clipping this for days.
That patient I just talked to you about, he had a car accident because he got a coughing fit in his car, and he got disoriented from the vertigo and crashed his car. Yeah. So he was really worried about, because you never know when you're going to have to cough. And if you're in a bad situation, like if you're going down a set of stairs and you start to cough, he was worried that he would take a tumble down the stairs or things like that. So it's an interesting case. We look for that in patients, by the way. I have them with video goggles on. If I'm concerned about unilateral vestibular loss, that's one thing I look for, which is a little odd. The patient's there and I ask them to cough looking for nystagmus. So
yeah, I think what's cool, and I get teased about this by my husband sometimes, because I think the more I have learned, and I'm always learning, and I would say I still have a lot to learn based on today, but that's okay. I love it. I want to get an A+. So I think it's cool because you learn the patterns and what fits the diagnostic criteria and what all makes sense. And that covers you like very well. But there's going to be these edge cases. And if you see enough volume of patients at some point, maybe early in your career, maybe later, maybe, in the mix, you will get, the kind of the exceptions, and being to sleuth those out. It feels cool because you really are trying to help the patient. I mean, I think that's why we're all in this work, in this field. And we hate to see people suffer. So, and people, whether that ends up being a specific thing to be done for it or just lifestyle or just live with a certain small degree of symptom, having answers is, I find, very helpful to patients, understanding and kind of figuring out how to manage, because not everything has a magical fix like putting crystals back. So, that's I think one of the greatest value that
I think it's a good point. I think where that is especially true is when I see a patient who has acute vestibular loss come in, and they'll come in a wheelchair and they're a mess and they don't want to move their head and their spouse is doing everything for them. And it's really interesting after you've explained to them what's going on and you put them at ease and you've showed them what happens when they walk and move their head and bend and they start getting experience with it. It's amazing just how much at ease and how much more they want to do when they leave just that first visit, because they now have an understanding of what's going on. So I think that's so true.
Another thing that I've learned over the years is it's okay to not know everything. A lot of patients, early on when I first came out of school, like I had to do every test in goggles only. And, I had to do everything under the sun and understand everything completely. And I had to feel like a patient had to walk out of that first day with an answer, which is not the case at all. And, looking back at a case I had this year, this guy was really difficult and all of his testing was contradictory. It was all over the place. It really stung me. I reached out to Jeff. I reach out to anybody to kind of make sure I'm not losing my mind. But what I've learned is that it's okay to the patient if you need to take a second and say, I don't know. Let's figure this out together, because nobody else is figuring it out with them if they've ended up in your clinic. and they're scared and they feel like they don't understand what's going on. And if you take the time to try to piece it out, slow it down, do your research, listen to the podcast, watch YouTube videos, dig through the literature, and take your time to figure it out, it means the world to that patient. And then you usually come across something cool. Like this guy ended up having a vestibular schwannoma on one side and a hypofunction on the other from a completely different incident. This was all after he had a brain bleed 5 years earlier. So we had mixed central signs. We had a positive hyperventilation test on one side, but a hypofunction with a VNG on the other. Like it was insane. But once you piece it out, it all started to fall in line and make sense. But it took some time and a lot of confusion and a lot of phone calls.
Very challenging, because I always tell patients that defects we find don't come with a date on them for the most part. Like we don't know if this happened in 1982 or 6 weeks ago sometimes, and that does make it challenging to sort things out. And I've done this for almost 30 years, and I would, and this is all I do, I would say still 10 to 15% of patients, I'm like, I don't know. Well, we don't get an answer. So don't feel bad if there's patients that you just can't figure out, because I think even people that are very, very experienced sometimes get stumped. Just patients don't fit well into any diagnostic category.
But if you listen and you try,
go ahead. Sorry.
I was gonna say, if you listen and you try, you will make that patient feel at least 25% better walking out the door that day, that they're not alone, that they're talking to somebody who understands what they're experiencing. And if they don't have answers, it's okay. We're going to keep working to try to figure it out. And I think that makes people feel a lot better, just feeling like they're heard.
Even the researchers, they're honest. I'm always looking at articles and they'll say undetermined, right? There's a percent that, they often have all the technology. I mean, they've got the VHIT, they've got, any test that's out there, this is done by Johns Hopkins or wherever, and they're, and they have, run blood tests, whatever they got to do. And it's like that little percent can be undetermined. And I think that it tells itself a couple things. One is things can be elusive, right? So these conditions that are maybe in process of developing, a degenerative condition or the first episode of migraine you ever had, vestibular migraine, it's not fitting the criteria because you haven't had 5 episodes, that kind of thing, right? So that's where the patients comes in. And I think I often reassure my patients to say, I've ruled out some serious stuff, or, kind of what have we accomplished? And that, again, can be very reassuring and say, we're going to keep an eye on things, you're going to monitor, we can check in, and let us know, let's do the next right thing is one of my mottos. We should do the next right thing. So, and I think just, being a partner in the process, is good for the patient and the clinician.
Yeah, agree.
Jeff, Helena, always a pleasure. You both are welcome back on to Talk Dizzy to Me whenever you want. Please come. And to our audience, thank you always for listening. And send us questions. If you have some questions to stump us, to stump Jeff, to stump Helena, please send them in. Maybe we can do a repeat of this show. And
maybe you guys can try to stump me.
I was just about to propose that. We got to start collecting and see if we can stump Jeff. That'll be our next challenge here. Awesome. Thanks so much, guys, for joining us. And we look forward to doing this again.
Thanks.
Thank you.
This podcast is provided for informational purposes only and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition.
The content of this podcast is based on general knowledge and information available up until the recording of this specific episode. Medical knowledge and practices may evolve over time, and new information may emerge that could change the understanding or treatment of vestibular dysfunction. It is important to consult a qualified healthcare professional for the most up-to-date and personalized advice.
The information provided in this podcast is meant to complement, not replace, the relationship that exists between a patient and their healthcare provider. It is intended to empower patients with knowledge about vestibular dysfunction and its management, but individual cases may vary, and treatment approaches should be tailored to each patient's unique circumstances.
By listening to this podcast, you acknowledge and agree to the terms of this medical disclaimer. The organizers, presenters, and creators of this podcast are not liable for any actions or decisions taken by individuals based on the information presented herein. Always consult with a qualified healthcare provider for medical advice and treatment.